morning, everybody. So thanks for the opportunity to introduce the operation of the Hungarian Cancer Registry. First, I would like to talk about the estimated data of GloboCan, the estimated data of IARC. Based on those estimates, Hungary deals with the highest incidence and mortality in Europe, but these are good numbers, but estimated numbers. I think not only I think, but we think that the population-based registration can have a more reliable result to describe the situation. What is the aim of population-based statistical data collection? First is epidemiological assessment. We have to know the correct numbers. Next, this is a quality assurance for the healthcare system, and it can help in the design and development of oncological network. The cancer registry can support scientific research next to the own research of the registry and can support domestic prevention programs. In Hungary, the operation of cancer registry is regulated by a ministerial decrement and it defines that the report of the cancer cases is mandatory. Reporting of the cancer cases is mandatory. It defines the ICD-10 codes which must have been reported. In practice, it means that the physicians, the hospital physicians, record data in the hospital IT systems, and then the institutional ITs extract the report and submit it to the application of the Hungarian Cancer Registry. This figure is depicting the data flow of the Hungarian Cancer Registry. The axis is the communication between the healthcare providers, the hospitals, and the National Cancer Registry. Every doctor patient encounter must be reported to the National Cancer Registry, and if there is a mistake in the data, the National Cancer Registry reports back the data to the healthcare providers to correct the data. We receive data from other sources. One source is the National Health Insurance Fund. This is a domestic institute which is responsible for the financial background of every disease, including oncological diseases. Thus we receive all the treatment data from them. The Central Statistical Office is responsible for mortality data in Hungary, and the Hungarian Cancer Registry receives those mortality database from them. And that means that the Hungarian Cancer Registry can work with 3 different databases. One database is the own database of the registry, one is the treatment database, and one is the mortality database. And the Hungarian Cancer Registry has to perform annual reports, and those reports are sent to the National Health Insurance Fund, the Central Statistical Office, and the ministry which is responsible for the healthcare system in Hungary. These reports contain the annual new cases, grouped by disease type, grouped by sex, grouped by territorial and age groups, age categories. Hungary is a 10 million country. It means that the personnel of the National Cancer Registry is relatively low compared to the Western countries and compared to the northern countries. We have 2 administrators. We have 1 IT expert. I have now 2 postdoc researchers. 1 postdoc researcher, 2 PhD students, and I am the head of the department. We have 2 separate reports. One is called Jagen. It is incorporates the clinical data. One is the PodGen or PodGen, which is incorporating the pathological data, the result of histological evaluation. The reports must be submitted to the web-based application of the Hungarian Cancer Registry, and that means all the data collection is digital. We do not use analog data collection at this point. The report contains personal data, which allows to identify the correct patient by a unique social ID. It is TOI, name, and other data, status data of the disease, the date, status, and outcome. We have tumor-related data, the ICD-10 codes coding the disease, a morphology code, extension, and TNM code. We have treatment data in the reports, so not only the Health Insurance Fund report contains treatment data, but the hospitals directly can share treatment data with the Hungarian Cancer Registry, and we have to identify the healthcare provider, we have to identify the hospital, therefore we need some data about this identification. The Hungarian Cancer Registry has an interactive website which is publicly available, freely available, and if you go to that website, you can filter the data by age, by year of discovery, diagnosis, gender, county, and you will receive the data in 5-year age groups. Now we have to talk about the situation of the Hungarian epidemiology of cancer. It means that the Hungarian Cancer Registry are operating from about 2000 according to international guidelines. Therefore, we have reliable data after 2000, and this figures shows the situation from 2001 to 2019. So in this period, during this period, the mortality stagnated and the incidence increased in both males, in both gender. These are the case numbers from 2011 to 2022. The last 3 years is affected by the COVID, therefore the data flow and the whole healthcare system is affected by the COVID. Therefore, we have decreased numbers. This is not a Hungarian specialty, but every cancer registry in the world reported this situation. In Hungary, the most frequent malignancy is lung cancer. We have about 10,000 new cases per year, and unfortunately, it shows an increased trend. The next frequent malignancy is colorectal cancer, then breast cancer, and I know that Professor Listrika is interested in melanoma. Melanoma is in the 7th position. And unfortunately, almost every malignancy shows an increasing trend. I left out from the estimation the COVID years. In males, the most common malignancies, colorectal cancer, then lung cancer, then prostate cancer. And in females, breast cancer is the most common cancer type with more than 8,000 new cases per year, then colorectal cancer, then lung cancer. I asked about the quality insurance of Russia. We performed data quality analysis in the database of the Hungarian Cancer Registry. We had a cooperation with IARC, the International Agency for Research on Cancer. Therefore, they provided a postdoc researcher for us, and he analyzed the data quality, and we wrote a paper from the data, and we tried to compare our data quality with other cancer registries. The Ettalon, the most reliable cancer registries, are localized in the Northern Europe, the Scandinavian registries, the Finnish registry, the Sweden, Norwegian registry. I think we are far from the level of the Norwegian registry, but we are in match with the regional registries. Maybe in some parameters we have better results, in some parameters we have lower results. I think the strength of the Hungarian Cancer Registry is the follow-up. So we have the highest record per case inside the Hungarian Cancer Registry, and one thing which is not working properly, not working 100%, these are 2018 data, that the morphological verified cases, the percentage of the morphologically verified cases, unfortunately are lower than we could expect it. Luckily, in the past few years, we successfully improved this number. In 2024, this value was about 75%, which I think this is a good trend. There is another marker which is called DCO. That means death certificate only cases. That means these cases were not registered inside the Hungarian Cancer Registry, but it appears in the mortality statistic as cancer mortality cases. And in the case of the Hungarian Cancer Registry, this value was 2.3% in 2018, which is a little bit better than other cancer registries. And there is another marker called PSU %, which is cancer with unknown primary. The primary site is unknown, and it is 1.4 in case of the Hungarian Cancer Registry, which is a little bit better than that of the other registries. So we think that the most serious problem of the Hungarian Cancer Registry is the over-reportation of the cases, and therefore we have a lot of false cases inside the registry, which requires a very active data cleansing activity, we have an evaluation about the CNS malignancies, the central nerve system malignancies, which I think these diseases are coded the worst in Hungary. And we report back all the cases to the hospital to verify the diagnosis, to confirm the diagnosis or reject the diagnosis. And this figure contains with orange the number of the originally reported cases. The blue means the percentage of reliability, and it means that the reliability of those cases are below 60% in average, which is a very, very critical number, very critical situation. The most reliable department was, or institute was, the Neurosurgery Institute of Hungary. So we think that they know that what to operate, but this column means that they know only in 9 cases from 10. The Hungarian Cancer Registry is able to perform survival analysis. We have a paper that shows the situation in Hungary. These are overall survival data, and we compared the 2 periods, the overall survival of patient discovered in between 2001 and 2005. We compared it to that of 2011 and 2015. And we compared our result to the incidence data and the mortality data, and those 2 analyses was in accordance to each other. We found that compared to those periods, in the later periods, the survival of colorectal cancer is improved. That was in parallel with the incidence data. The incidence increased, the mortality decreased. In case of lung cancer, I think we did not have any significant step to heal lung cancer, unfortunately. Unfortunately, in the later period, the overall survival was impaired, and it was in parallel with the mortality data. The mortality increased during this period, but the incidence, the incidence is decreased in period. The mortality did not change too much. In case of breast cancer, the incidence increased, the mortality decreased, and luckily the overall survival improved. In case of cervical cancer, luckily the incidence and the mortality decreased, but unfortunately the survival did not change significantly. And I think the best data was in prostate cancer among those patients, those diseases which were analyzed. The incidence increased, the mortality decreased, and the overall survival showed a more favorable outcome in the later period. That was overall survival, but nowadays the epidemiological experts think that overall survival is not the best method to evaluate population-based cancer registry. The Pohár-Perme net survival method is recommended, which is used one of the most famous work groups, Concord 3, which evaluates global cancer survival. But Hungarian Cancer Registry is able to provide Pohár Perme net survival estimations. We found that most of the cancer cases, the survival improved, which is very good news for the Hungarian people. And we tried to put those data in European context. We can believe some result and we do not believe some result, unfortunately, because it shows that the best survival in Europe is in Hungary regarding pancreas and lung cancer. And I cannot believe it because so this situation, the explanation of those situation can be the falsely reported cases, the high number of falsely reported cases. And this is a separate examination. We tried to compare the database of the Hungarian Cancer Registry and the database of the mortality statistic, and we have this is the Hungarian death certificate, and based on the certificate we can identify that the patient that autopsy was performed or not when the cause of death was recorded to the death certificate. And some experts think that the high mortality of Hungarian cancer registries is explained by the high autopsy rate. Hungary has traditionally a very high autopsy rate. Before the COVID, we have 40%, but the European average was below 10%. So that means in the European Union we have the highest autopsy rates, and if you perform more autopsy, you can discover more cases by autopsy. And based on the Hungarian Cancer Registry and the database of Hungarian Statistical Office, the mortality database, we identified all the autopsy discovered cases and tried to correct the numbers. So we evaluated that the autopsy count in case of total malignancies about 7%, 7 to 8%. That means from all cancer mortality cases, 7 to 8% is discovered by autopsy. We categorize the result by cancer type. The most common cancer type in Hungary is lung cancer. Lung cancer is in this row. That means 10% of the cases are discovered by autopsy. And in colorectal, it is about 5 to 7%. In case of the liver cancer, that was the highest percentage. It was almost 25, almost 1/4 of the liver cancer cases, liver cancer mortality cases were discovered by autopsies. But liver cancer is not a big issue in Hungary. This is luckily relatively more rare malignancy. And what does it mean? So these are the European mortality data which is available in Eurostat. And it shows these are population-based data based on the collection of death certificates, and it shows only the lung cancer mortality. These are standardized data, and based on the population-based data, Hungary is the leader in lung cancer mortality among European countries. If we adjust this number with the autopsy-discovered cases, eliminate the autopsy-discovered cases, that is the situation. That means it counts, but not too much. Hungary is still the leader of European lung cancer mortality. This is not the good news for Hungary, but I always receive questions that what is behind those terrible incidence and mortality numbers in Hungary. And I can explain it by the evaluation of OECD. OECD performed the evaluation of cancer risk factors in European countries. They found that Hungary is not a leader of any factors, but Hungary is in the leading countries in most of the factors. One was the exclusion, HPV vaccination. HPV vaccination has a good situation in Hungary because the vaccinated rate is very high compared to other European countries. But unfortunately, we smoke a lot. Not the most, but a lot. We drink alcohol, not the most, but a lot. So in every factors, we are in the bottom third of EU countries. In summary, the most effective way to evaluate cancer burden is the population-based registries, which can help the establishment of oncological network. Hungarian cancer epidemiology is one of the worst among European countries, and Hungarian data quality should be improved, and the Hungarian National Cancer Registry is able to adopt international guidelines in the assessment of cancer survival. So thank you very much for the opportunity. So I'm the only presenter in the stage, but this is not a one-man show, so I would like to thank to my former and present bosses, my closest colleagues, and the colleagues from IARC. Thank you very much.